Good evening, colleagues. This evening, we're going to speak about an article published in RadioGraphics in November this year. Its title is Respect, which is an abbreviation for a research group called Radiology Employees Striving for Productive and Effective Communication. These are the characteristics of the article. It's part of the practice policy and quality initiatives of radiographics. It's from the Department of Radiology in Cincinnati Children's Hospital, Ohio, and the Department of Radiology of the University of Cincinnati College of Medicine, also in Cincinnati, Ohio. To introduce, they mentioned that effective communication is essential for healthcare entities. It will enhance the quality of safe patient care. Even being crucial, effective communication still remains a challenge whenever we have to deal with people. And the objective is to avoid serious safety events when we accomplish effective communication. On a counterpart, ineffective communication, which mainly is due to lack of attention, lack of understanding, and lack of respect, is a phenomenon that has particular traits in the healthcare setting. Some of the specific contributing factors in medical practices are increasing workloads, increasing reliance of technology, and less reliance on face-to-face communication, especially seen in our specialty, namely diagnosing by imaging. We also have an increasing distance between sites of care delivery, and we have increasing loads of stress. So lack of respect is particularly troublesome. We had seen that this is one of the contributing factors to poor communication. And some of the identified components of lack of respect are disrespectful words, tone of voice, body language, and another concept that they will explain a bit, which is the power gradient. When a person in higher title or with a higher role in any company is using that as to create a distance or a patronizing attitude towards employees. So this, of course, has its negative impact on a health team, where you have the fact that physicians, they need to rely on their healthcare workers to get information about patients, basically from nurses, technicians, technologists, and all the staff that are involved in the patient care. They provide useful and essential information to the physician team. But if we have a lack of respect, then there is less likelihood to report warning signs early, so there is a greater risk for the patient. Frontline workers perceived disrespect by physicians in general. It has been researched and concluded. So this is also addressed. This is a quality improvement project where the focus is improving interactions between radiologists, technologists, child life specialists, and reading room assistants, with the goal to increase the median percentage of answers in the questionnaires deemed very good and excellent interactions from the 48% at baseline to 90% at the end of the project. So the methods of this study, first to mention a bit of the setting, we mentioned that it was done in Ohio. It was done at a large children's hospital where you had 35 radiologists, where you had 12 pediatric radiology fellows, where you had almost 200 radiology technologists, where you had 12 reading room assistants, where you had 4 child life specialists. The imaging was acquired at 11 sites across the whole city, and there were 3 of these locations where radiologists were on site. The rest of them were without radiologists physically present. Then you had reading room assistants at the primary location only, and interactions in person and by telephone at the central location and by telephone at the centers where, the 8 centers where there were no radiologists physically present. So as for the baseline data collection, first the problem was identified by the team of quality control and improvement at this hospital, and a multidisciplinary team was designed where different sub-teams of this bigger team were to identify root causes of lack of respect and other causes of deficient communication to offer specific solutions to correct specific behavior. Now, they went about this in an interesting manner, very orderly. They respected what's called the Chatham House rule, where you have meetings. They did it at a weekly frequency, where team members gather and are enabled, they're allowed to share different anecdotes or different situations from the workplace. And basically, the rule states that when you share these stories outside of the setting of this closed meeting, you're only allowed to share the scenario itself, but not the persons involved. You cannot identify the people that are involved in the story. So say that a technologist wants to share a story outside of this meeting, just to help others to see the point made in the meeting. Well, he's allowed to share the scenario, but he's not allowed to mention who were the people involved. So the RESPECT, which is again an abbreviation for Radiology Employees Striving for Productive and Effective Communication team, they were working on the perception of interactions between radiologists and the technologists. So they conducted a series of surveys during the period, and here to see the table 1, these are the different questionnaires, and they basically were modified to end up with the last column where we had surveys 10 through 17 using the full survey mentioned there. They had to score, some of the answers were free text answers, so they could write their answers freely, but other answers were provided for other questions with 5 potential answer choices as excellent, very good, good, fair, or poor, so in this range. Basically, just to go through the item numbers, they had to show how much they agreed with, for example, I am comfortable seeking guidance or support from radiologists. I'm treated with respect. Overall, how would you describe your interaction? Any examples of interactions that support your response? Name one radiologist that you have worked with during the last 2 work days. How would you rate the interaction? Good, fair, very good, excellent, etc. Why did you rate this interaction as this or that? So basically, when they started getting the information from the interactions between the radiologist and the frontline staff, they gathered both perspectives. Of course, the radiologist perception of the frontline staff and their interactions with them, and the frontline staff members' perception of their interactions with the radiologist. So you had 3 major instances where you had disrespectful behavior between these 2 groups. It was in-person interactions, telephone interactions, and training interactions. So different teams or sub-teams were assigned to research and to do different tests to see how to improve the respect and the communication in these 3 areas: in-person interactions, telephone interactions, and training interactions. So that's what I mentioned, 3 subgroups of teams where we had root causes for negative interactions identified, like what's happening, why is something happening wrong here? So they then designed potential interventions where tests were conducted by each subgroup, and they used the methodology of Plan, Do, Study, Act, which is referred to as PDSA. So they plan, they implement, they do feedback. They see how its effect are perceived, and then act. So the interventions on outcomes are these. We will refer back to these several times, but this is basically like dividing by category, as we mentioned, and the intervention and the results. So they either modified, adopted, or abandoned the intervention accordingly. So here you have the change evaluated. These tests of change, they were evaluated with the PDSA ramp. So what, as I mentioned, the team either abandoned, modified, adopted, or expanded the intervention according to the results of the same. This was not a matter of measuring individual interventions. Rather, the whole sum of interventions was measured because they had no way of knowing which intervention at large was the one contributing to the overall satisfaction or improvement of communication. This will be referred to later as well. So the first intervention in each group was focused on awareness, just creating the awareness that this was a problem. So first, speaking of the interventions, the in-person interactions, you had two locations where there were problems, both in the reading room and outside of the reading room. One of the identified causes was a disrespectful tone of voice. Another would be a disrespectful body language. For example, the lack of eye contact. The radiologist receiving a visit from the technician or technologist and simply continuing watching the screen only, maybe ignoring the question or answering but without having proper eye contact, and also the habit of eye rolling, which somehow is interpreted as despotic or lack of respect. Then they also, of course, emphasize that this is not about hammering one side of the team. They had an approach where they balanced interventions between the psychological safety of the frontline staff, which is emphasized and stressed, and the timely and private feedback to radiologists. So here you have, for example, the telephone interactions. They were like creating a script for identifying oneself when answering the phone. Instead of saying radiology or being very brief in the introduction, they were trying to have the doctors say at least, okay, my name is so Hansen, how can I help you? And you go on. So as for another problem, the number of unneeded calls that were received at the department, which was a big source of frustration for the radiologist. We know that well, that when you have an overload of interruptions, it can affect the quality of achievement. So they implemented an automated call distribution system, which then was adopted because it helped to triage the calls to a more appropriate location if necessary. Then you had in-person interactions and the training interactions as well. This was, as I mentioned, the three major issues at the telephone interactions were the negative tone of voice, the incomplete information transmittal, I mentioned that, and the frequent radiologist interruptions, as I mentioned. Then you had the in-person interactions, which is they measured the positive and negative interactions in the quality control area. But the technologists, they didn't answer these questionnaires. So they moved to, this was in the quality control area, like an office and at a different location. But then they said, okay, let's leave the questionnaires in the reading room. But they had to abandon that as well because, first was modified, this was abandoned. The technologist did not tally the interactions. So then again, when they implemented secure messaging application during conferences, for example, there was an academic activity and technologists were frustrated because they felt that there was no radiologist to respond to emergencies during the academic activities or conferences. So they tried to apply a secure messaging application so that communication could go on during the conferences, but this was also abandoned. This article describes quite closely what methods were abandoned, modified, and the whole chronology of it all. So they changed the schedule, and what they did finally, which was adopted, was to assign a radiologist that was covering all needs at the working station during the conferences. So you would have one radiologist staying in the office while the others were at the academic activity, and this would improve this relationship also. There was someone to respond to the need when needed. So other things like individual survey responses shared with the radiologist. And yeah, this was adopted because they were routinely notified how they were perceived by the technologists. So it was important for them to have feedback on their behavior. And yeah, also they created opportunity for technologists to shadow radiologists in the reading room, but this was abandoned because the technologists could not easily get away from their clinical duties, so it wasn't feasible. So when it comes to trainee interactions, the people, the fellows, and like the people that were training at the site, there were several root causes of problems with this group. The fellows, they didn't know the technologists well. That was one of the causes. They were unaware of the work effort implied with pediatric patients. That is quite difficult to accomplish a good quality study, and to have understanding of the different factors that are involved were important to help the technologists to improve the quality of their imaging acquisition. So also the fellows were not oriented appropriately from the beginning about the desired departmental interactions. So they would be a bit clueless, okay, what is expected of us? What should we do? And so they didn't really know. Also, shadowing was proposed of the trainees with the technologists, so that the trainees would be with the technologists for some time. And also another intervention were the social events that also improved their interaction, and the orientations that were specific on phone etiquette, how to respond when you respond to phone, the appropriate body language that's expected and respectful, and the general goals of the improved interactions of the whole team. So the continued data collection that continued over a long period of time on a 4 to 6 week interval basis. This was conducted. I mean, several surveys followed, and significant improvement was perceived if there were 8 consecutive measurements where all were above the baseline or current median value, where the results would have to be very good or excellent, and these were tracked. So the figure 1 here shows very interestingly that the green dotted line here was the goal. This is where they wanted to push the red line, which is the median percentage. Remember that average is not the same as median. You can have scattered results and you can still have like good peaks, but then the median value is kind of like the more stable representation, statistically speaking. So this is what they wanted to improve, and it remained at 75, starting from 65. So they did have one measurement of 90. We'll speak about that later and what that means. So the results. The frontline staff responding to the survey were 63 staff members in total, which represents 32% of the whole staff group. And the results showed also that the responses deemed as very good or excellent interactions were only 48% of all interactions. So it's kind of like a negative start, as to speak. Less than half of the interactions were perceived by the support staff, by the technicians to be good interactions. And the radiologists analyzing them, on the other hand, at the baseline, 85% of them participated, 28 in number. And the interesting thing here is like it's quite different. 96% of the radiologists deemed the interactions with their colleagues as very good or excellent. So no routine surveys were followed in this group of the radiologists themselves. Basically, they just did another survey a year later to see how they perceived these interactions, and it remained pretty high, 95%. It's interesting to compare how the radiologists perceived their interactions and how how the radiology technicians did, which was very disproportionate. So you had a period from July 10th, 2018 to February 10, 2020, where you had a total of 17 surveys, where you had a range of very good or excellent, starting from 65 to 90, the peak. And the current, at the moment of the publication, because the project is ongoing, the median value was 75% of the responses that were very good or excellent in terms of the interactions, right, between the team groups. So the initial median performance was 65%, so you have a 10% increase, and when you remember that it was 48% average, 48 to 90 or 48 to 65 respectively, if you compare median or average. So at the baseline, 46 of the comments were negative versus 12 positive, which is a relationship of 2 to 3 to 1. So you had more negative comments than positive in the beginning. Here, for example, they show some examples of positive or negative comments, or some are mixed. For example, you have Dr. So-and-so is amazing. I love working with him or her, or here they say them as plural. Some express that, yeah, this doctor, he or she feels that somehow he or she is better than I am, that expecting, that a bad attitude would be taken out on me, that maybe that doctor will have like a stress problem or something, and then takes it out on the staff member. The staff member is not the one that caused the problem, perhaps, but there is something that happens, and then the radiologist will take out that stress on the staff member when it was disproportionate and not really something that was deserved at all. So you have some people there of the radiology technicians responding that they felt very comfortable talking to this and this physician, but other comments stating that sometimes radiologists seem irritated that they have to check studies over the phone. I know that they are busy sometimes too, but this is protocol when things aren't normal. They will ask me questions multiple times, which means they're not listening to me when I'm presenting the case. Another comment, they are busy, of course, but this is disrespectful, how they respond and so on. So, of course, this is one side of the perspective, but it's still very important, I think, to listen to these voices. Then you have in-person interactions, like, okay, this person was in ultrasound on Tuesday, was great, happy to help with anything and everything. This doctor is so friendly with patients, families, and staff. They came back and visited and just thanked us for the day and say goodbye. Radiologists always seem bothered when we let them know there are teleradiology studies to be read. They get frustrated and so on. I have had more than one technologist complain to me about the same radiologist rolling their eyes during conversations. No one responded or even acknowledged I had asked the question when a technician entered the reading room. Sometimes we were met with anxiety and frustration. This doctor is rude, he's nasty or she's nasty. They talk over us, technologists, like they're being patronizing, in other words, and this is unacceptable. If we would act in this manner, we would not have a job, etc. This doctor was very helpful this weekend, always treated me respectfully. This doctor is always so nice and personable. I am not always comfortable seeking help from the fellows, but from the radiologist, yes. That was another answer. Some of the fellows are less confident, so that was an issue as well. The lack of experience in some issues, not stating who they are, maybe insecurity again, like answering the phone, not saying who they are, but just like giving an answer without really wanting to be known for who they are, maybe, perhaps. So this figure is showing basically that the positive answers during the whole period were double than the negative. But you see in the beginning, like each color represents a different questionnaire. So in the beginning, you had less positive answers, but negative a lot. Like negative interactions were perceived as more in the beginning. Here, less positive. But as time went on, you see that the negative ones are reduced and the positive ones are significantly increased as they were applying each of these different interventions. You can see here 12 versus 46 in the beginning, and then 61 positive versus 13 in the end. So it's a positive change. There you have the figure 3, which is the stacked bar graph. Basically, this is like representing each and every one of the individual radiologists. When they received these charts, each radiologist knew who they were, like they were assigned a number, but the other radiologists did not know which number the other was. So it was anonymous, or it was like confidential, but at the same time, it was you could receive specific feedback yourself. So this was very good. And you see here that these are the positive interactions, the frequency of positive interactions, and some start like really low and then they kind of start shooting up. So they were having like a change, positive change from the beginning, where they have like few positive comments about this radiologist, and then in the end, a lot of positive comments. This particular radiologist, I find it interesting that they had like good response all through, even from the beginning. So some people seem just to be nice and friendly from the start. Here you had the negative interactions. This particular radiologist received a lot of negative comments, some none at all. Not all received any comments, so it seems that, yeah, not all had an issue to be addressed, at least from the staff point of view. When it comes to the discussion, we mentioned that ineffective communication is a cause of failure in safety events, where the power gradient, one person with less power not feeling he or she can raise a concern, like feeling, oh, should I ask this or not? Maybe I will get scolded, maybe I will be mistreated. So if I just don't say it, then nothing will happen, and at least I will have a peaceful day at work, as to speak. This produces job dissatisfaction, poor patient experience, because significant safety concerns are not addressed in time, and the patient is the one that suffers from this bad communication between the doctor and the other staff members. So this produces minor and major patient safety events. Improved communication has been a national patient safety goal in the United States by the Joint Commission that has the task of validating about 22,000 health institutions and projects all over the country, and also has an international role. Ever since the year 2003, yearly they have presented improved communication as a goal for patient safety at a national level. Yeah, saying the same again, but just stressing this point. So they have used standardized tools, for example, timeouts before procedures. So there's an intervention that is going to happen in the clinical setting, and the team gathers before and goes through the list of expectations and so forth. Daily safety huddles, as in meetings where like the important points of safety are addressed. The creation of safety hotlines, so you can call somewhere and you can be completely at ease with that you are confidentially treated. The information that you're giving is not going to be used against you, but you can address issues and concerns and so on. So this is like, you know, what the Joint Commission has been working with. So the thing is, like, safety events still occur, and an example is the never events, things that should never ever happen. Wrong site surgeries or procedures. So you have like a nephrectomy on the contralateral side on a healthy kidney, for example, where the other kidney was the one affected and should be operated, for example. So this is like wrong site surgeries or procedures. Then you have the wrong patient surgeries or procedures, like you are mistaking the patient and doing a surgery or an intervention or procedure on a patient that was wrongly identified. Or retained objects, like, yeah, we don't have to go into details, but we know all of this. So this happened 4,000 times per year in the United States alone, when this particular reference was researched. They're referring there to a specific reference. So, of course, this is stressing the need of quality improvement, routines, and forums. And in this context, the hospital, the Children's Hospital, where the study was conducted, acknowledged the problem, saw a change was needed, that there were negative interactions between the radiologist and the technologists. So they wanted to do a change of the departmental culture with multiple small tests of change, which we have been seeing during this presentation. they wanted then to improve the interactions between the team workers. So 2 types of interventions were analyzed as a matter of discussing now the results. The behavioral, which are tough and deep-rooted, so they require an individual to change, and other problems related to as in system-based issues as well. We'll mention that in a while. So the assumption of the research team, RESPECT, in other words, as it was abbreviated, about the radiologists, the physicians specialized in diagnosing by imaging, was that these physicians did not want to be perceived as disrespectful. They were like not wanting to be mean or bad or rude with their colleagues and staff members, but simply did not realize the effect of their body language and the tone of voice. So they were like perceived to be unaware. This was the basic assumption, that as expecting the best, so to speak, of the physicians. Of course, you guys want to be good people, but you don't realize that you're actually acting in a way that's not constructive, so to speak. So first then, that is why we mentioned that awareness was targeted, like the importance of, hey, guys, this is happening. We need to realize, so to speak. And sharing anonymous anecdotes was seen as a very effective, perhaps the most effective interventions was to share anonymous anecdotes, like so-and-so thing happened, like to just tell the story of something happening, but keeping it safe for the team members, not mentioning who was involved. Then, of course, like several issues addressed, as we mentioned, the eye contact, the courtesy involved in greeting, introducing oneself properly by phone, all help to bring about effective communication. So as of the feedback and the focused coaching of the radiologist, you had one-on-one sessions with a coach and a radiologist on another hand. So what was seen, which is very positive, a good trend, is that the radiologist really gave evidence of a notable effort to improve their interactions. They really proved to be motivated to improve this problem, to improve their abilities to communicate. And some even sought external help to improve their interpersonal relationships and their communication skills. So this is very important, because this, as I said, this is a two-sided issue. This is not only like focusing, okay, what should the radiologist improve as perceived by the technologists? No, it's also the system-based issues. For example, the increased stress load for the radiologist and the staff members as well. So what they were trying to produce here was a decreased number of phone calls to the reading room, because these interruptions, they are deleterious. They're not producing a calm environment and focused work. So this brings about frustration, and then it's like a risk factor having many phone calls received at the reading room, especially phone calls that are not really designated to be answered by a physician there. By trying to decreasing these phone calls, they were then trying to decrease the frustrations, and this frustration that would many times, unfortunately, lead to bad behavior from the physician or the radiologist. So this is a separate project about the interruptions, but it was conducted at this very same hospital simultaneously, and it continues still. So, but they were not describing the results of this, because this was not the aim of this study. This was part of the interventions that were affecting the radiologists as so. So the main initial goal of having the interactions deemed as very good or excellent increased from 48 to 90% was achieved at one survey. I think you remember in the curve you had one peak going up to 90%, but this they did not perceive the goal to be yet achieved just because they had one result at 90. What they want is sustained improvement measured by the median percentage, which is, like, as I mentioned, the more stable representation, statistically speaking, being equal or above 90%. They're currently working on intra-team interactions between radiologists and between radiology technicians to create a culture of feedback between team members. So some of the limitations was that you had a low response rate, 18 to 38% is pretty low when you look at the staff group of staff members. Also, they could not measure the impact of individual interventions. For example, they did this about teaching fellows how to communicate themselves properly by telephone, but they don't know if that improved the overall satisfaction, because there were simply so many interventions that were made. The surveys measured the overall improvement in communication at the workplace. So they were not able to identify the useful interventions or to discard the ones that were not. Another limitation is the Weber effect, where people improve simply by knowing that they are observed. So, hey, I better take care now because they're doing this study. And I don't want to be perceived as a nasty doctor, so let me shape up and behave well because now they're actually doing this research. So this would be like the Weber effect. Then again, they stress in this study that they were focusing on awareness. So even if this was happening, like people were a bit stressed, saying, okay, now I will speak well, I will communicate with kindness and respect because they're doing this research, at least they're actually creating awareness. So on the long run, it actually might be effective still. In conclusion, this is a project using quality improvement methodology to improve interactions between radiologists and frontline staff. They saw a modest improvement, but they still recognize humbly that there is significant work ahead. Their hope is that this will provide a positive framework to help other departments with similar problems. So I thought this very useful, a review that is very relevant and good to address and to apply accordingly at different workplaces. Of course, any company, any industry will have its issues when it comes to interpersonal relationships. When it comes to healthcare, you have particular traits and characteristics of communication that are very important. The basic thing is we don't have a product that comes out with faults, like technical mistakes only. We have someone that might pay with their life or with their health. So this is a very important thing to address, especially in the healthcare setting. Now, coming specifically to the radiologist setting, you have different factors that are not seen in other settings, as was mentioned in this study. So they're applying many known concepts when it comes to communication skills, improving them at the workplace, but applying it to the setting of radiology, which is, of course, particular, as I mentioned. So I hope you've enjoyed it. I hope it's useful in your work setting, wherever you are working, where you're listening to this. And yeah, thanks for listening and have a good evening. Thank you.